I know, I'm fine. Thank you, Michael. And thanks for turning out. Just for comparison, they told me that when they have women's events, twice as many people show up. So I think that reflects the men's attitude toward prostate cancer. This is our agenda today. We're going to briefly talk about the prostate, the diagnosis. There's a lot of controversies that have emerged. A lot of these have emerged just this year. In fact, there was a big conference that I'll talk about that was held at National Institutes of Health just this past month. And there's some new things that have come out on treatment options. And then we'll talk briefly about prevention. Some basics about the prostate. You don't want to confuse prostate enlargement without cancer with cancer. Of course, prostate enlargement occurs in most men at age 50, and it causes a lot of the urinary symptoms. Unfortunately, there are no specific symptoms for prostate cancer, but the patients, when they come into our office, we're screening them for cancer as well as determining. That's the first thing we have to decide. Are we dealing with an enlarged prostate that has cancer or just something that has benign enlargement? That's often referred to as BPH. But BPH is quite common. If we had a graph showing cancer, it'd be 1/6 of that number. So you'd see a similar line, but it'd be quite a bit lower in its ascent. So you can just figure that BPH is probably 6 times more common than prostate cancer. And of course, with management of these enlargements without cancer, we've got medical management, we've got herbals, we've got the minimally invasive therapies, and of course the surgeries like laser and TUR. None of those surgeries have any role in treating prostate cancer. Of course, the enlargement can cause the bother that usually brings the patient into the office. And patients will come to the office for screening for prostate cancer perhaps because their PSA has been picked up by their family physician, or an abnormal digital rectal has been found, or they'll come in because of these symptoms, and the symptoms are basically the same. Cancer we have to diagnose ultimately with a biopsy. There is no other way to determine a diagnosis. We have other things like PSA, and we've got the digital rectal exam. And statistically, there are going to be about 241,000 new cases this year, and there'll end up being approximately 34,000 deaths. When we had prostate cancer treated 15 years ago, 1 out of 2, almost 50% of the men that walked through our office had disease spread elsewhere. So they came in with metastatic disease. Now that's down to 1 in 20 because of PSA. And that's led to a big controversy. And the U.S. Preventive Service came out with this statement this year that said, well, current evidence does not support the use of PSA for screening. And what they really meant to say is that PSA by itself is not specific. You can't take a PSA and say this man has cancer based on it. But if you have PSA and you have comparative PSAs, the rate of change of that PSA is cancer specific. The elevation of that PSA in relation to that man's age or size of the prostate is cancer specific. So the American Urologic Association came out with a statement. They said, well, at least inform them, but they're still recommending treating or at least screening everybody with a PSA at age 40 and above. Now this is where a lot of the new controversy has come in, watchful waiting. The new NIH, and you can go to NIH and get their consensus statement. They have some beautiful documents online, and 2 papers were presented, one of which was a prospective trial. And they took these men and they did what's called watchful waiting or surveillance. Now there's a big difference between watchful waiting and surveillance. Watchful waiting means you're just going to wait to see what happens regardless, whereas active surveillance means you're actively surveilling this patient to catch cancer and treat if necessary. And what they found is in the randomized arm, that there was actually more deaths in the men who were treated with surgery than there were in the arm that was treated with watchful waiting. But we have surgery, and that's the main way people are treated for carcinomas of the prostate. We've got a multitude of radiation therapies. And Jacksonville is unique in that all of these therapies are available. If you go to Daytona, for example, only the IGRT is available. They don't have the proton beam. They don't have a cyber knife. And actually, they don't have a robot. Whereas in Jacksonville, we have, I think, 10 robots now. Cryosurgery is available. HIFU, the high frequency intensity ultrasound. These therapies are very rarely in place in one spot. I bet you can't find another city in the United States that has all of them all right here, maybe New York. 99% of them are adenocarcinomas. For the rest of this talk, just assume that's what we're talking about. But there's huge variations in the aggressiveness of these tumors based on the grade, the amount of the tumor, and the stage of the tumor. And you have to take into consideration the side effects of the treatment, which is a big deal. So basically, we've got, again, watchful waiting, surgery, radiation therapy, and then at the bottom, we've got the cryosurgeries and the HIFU. Well, where do you start? Why is there not one therapy? Why do we not apply surgery to everybody? Why is there no standard? And that's because you can have such variation in the aggressiveness. Again, the grade can make a difference if he has multiple biopsies versus a few. The grade we use is called the Gleason score. And unfortunately, this is a very subjective way of the pathologist looking at the tumor and telling you how aggressive it is. There's huge variations and lawsuits that come out of people misinterpreting the aggressiveness or the grade of these tumors. They look at two areas. The first number is the majority of the cancer cells. Then they look at the minority of the cancer cells and they add those two together. Now, 50% of the tumors will come out Gleason 6. And the grade, that's a total number, 3 plus 3. We very rarely see total numbers of 2 to 5. So I've never seen a 1 plus 1. I think I've seen 2 plus 2s in my lifetime. Very rarely see a 2 plus a 3. A 6 is usually the most common one that we see, and that's between 50 and 60%. The next most common is the number 7, where you have a 3 plus 4 or a 4 plus 3. Now, the first number being the majority of the cells, if that's a 4, we think of that as a much more aggressive tumor than the 3 plus 4. That's just something to note. The most common tumor after a Gleason 6 would be the Gleason 3 plus 4, fortunately. Then Gleason 8 through 10s, those are the aggressive ones. We think of those as freight trains. You can't get out of their way. You've got to treat those aggressively because those are the tumors that kill people. Fortunately, those 8 to 10s are not very common. Staging is basic like any other type of staging of any other tumor anywhere. You want to categorize the spread beyond the initial organ, in this case the prostate, and it determines the probability of being cured with any given therapy, whether it's surgery or radiation. You want to know the size of the tumor, the extent of the lymph nodes, and we usually do a CAT scan or an MRI to determine the extent of the lymph node involvement. And metastases. Prostate cancer tends to home in on two areas. One is the lymph nodes, and the other are the bones. For some reason, it loves to go to bones. So we always get a bone scan, and we always get a CT of the lymph nodes. Other tumors, like kidney, tends to go to the lung. You look for the lung first, but this particular tumor goes to those areas. The stages, there are various stages, but the ones we most deal with are T1C. And this is important because if you're looking this stuff up online, you've got to know your stage if you're trying to research what you want to do. T1C is somebody who has a prostate cancer that's been diagnosed by PSA alone. That's probably our most common diagnosis. T2 means that the doctor felt a nodule. That can be more serious or less serious. Some of those patients do better than T1Cs, but it is an upgrade in stage. T3 is where you can feel the prostate tumor and it's already going outside the prostate. That's fortunately not that common. And T4 means that it's already spread to the bones and lymph nodes. Again, remember, 15 years ago, 40% of our patients walked in as were T4s on diagnosis, and now that's down to 5%. Now, the watchful waiting has become a big buzzword, and this is mainly for Gleason 6. Again, the majority of prostate cancers are the Gleason 6, the 3 plus the 3. And what they found is the 10-year survival rate for these people is as good as surgery was. So it makes people sit back and say, perhaps I don't want to go through radiation and the side effects or surgery and the impotence, the incontinence that might occur. I'm going to watch this thing. Because sometimes the cure is worse than the disease. So watchful waiting, especially after this new NIH consensus, this is what is new in urology. Now there's again a difference between active surveillance and watchful waiting. Watchful waiting means you're just going to wait and see what happens. You're going to wait and see if he has metastases, and you're going to watch that. That's not what we're doing. We're talking about active surveillance. We follow the patient, and up to about a year ago, that meant that we had to biopsy the patient every year to make sure that the tumor hadn't progressed. Well, if you've known anybody who has had a biopsy, they're not that bad, but they're not innocuous. I mean, they have side effects. So they've kind of modified that. Now they're looking at MRIs as a possibility of following people and determining if they can be watched instead of just treat them right now. Then if the PSA goes up and we re-biopsy them, you can decide if you need to treat. For example, I had a man with a Gleason 5. He had a 2+3, a young man, but he did not want to go through any of the therapy. Did not want surgery, did not want radiation. We followed him, and his first PSA jumped. A normal PSA is 4 or under, and his PSA on diagnosis was 4. But when he came back 3 months later, his PSA was 12. So we immediately re-biopsied him. His Gleason 5 had gone to a Gleason 8. Now we had that freight train coming down our throat. We had this big tumor. We had to rush to get him to treatment. So that's what we mean by active surveillance. If he had stayed like most of our patients, his PSA would stay the same. We'd just watch him, and we wouldn't have to treat him. One of the main ways people are treated now is surgery. And of course, if you go to a barber and ask him if you need a haircut, what's he going to say? Yeah. Same thing if you go to a baker, you're not going to walk in and say, hey, give me a sirloin. You know, if you go to a surgeon, and I am a surgeon, we're going to push surgery. We have 2 robots at Baptist, actually 3. We like to do the procedure. They're fun. We get well reimbursed. We go to meetings and we talk about how many prostates we've taken out. Well, I've taken out more than you. Or I can do it in 1.5 hours, or I can do it in 1 hour and 15 minutes. You know, they brag about that stuff. 15 years ago, it was a different thing. It happened to be neobladders, making artificial bladders. Now it's using the robot to take the prostate out. And it has a lot of advantages. You can reduce your hospital stay to only a couple days or 1 day. And the nerves of the prostate, they come down along the prostate, and these are what go to the penis to keep it active. And if you damage those nerves by taking those nerves or even pushing them away, that's where the robot helps. You can get those nerves off. You can see them much better than we ever could see, even when we use magnifying glasses during surgery. So 85% of prostates that are removed now are taken out with the robot. It's pretty much taken over, and it's become the standard. There are still doctors who don't use it, and that's fine, but 85% of doctors do this. It hasn't really improved our impotence rate. It has improved our incontinence rate, but the main thing it hasn't improved is the positive margin rate. What's the downside of surgery? Why do people not all have surgery? Well, in higher grade tumors, especially when you get into the 4+3, the 7s, the 8s, the 9s, they have a higher percentage of positive margins. And if you leave a positive margin, now you've got cancer left behind. The guy's gone through the surgery, and he still has to deal with the tumor. In general, there are better outcomes with less incontinence, less impotence, shorter hospital stay, less blood loss. The average blood loss for a radical prostate open was approximately 2 units of blood. Now it's very rare to even lose 2 tablespoons of blood. But again, the surgical margin issue is not improved from open to using the robot, and that's the issue. That is why other therapies are used, especially for the higher grade tumors. Because if you've got a 50-50 chance of having a positive margin, maybe you perhaps wouldn't want surgery. Perhaps there's another way you could treat it. And in fact, other therapies work better than surgery in those higher grades. Well, if we go back, these yellow lines that are coming down along the prostate represent the margins, and they hug the prostate like a piece of saran wrap, and they're enveloped. They're not one nerve, like you can look at a nerve in your leg or your hand, and the surgeon can actually find that nerve. You can't find these. They're in a fan of little teeny minute nerves. Unfortunately, that's exactly where cancer invades the margin. When we get a positive biopsy that says perineural invasion, often the pathologist will say that. It's very controversial in urology. That's how the cancer is actually escaping into these sheaths. That's the first way it'll get out. And then from there, it can go into adjacent structures. Most often what happens is it just sits there and grows locally. So I've got patients who had a radical removal perhaps 15 years ago. Now they've got a new prostate that is regrown, and it's malignant. And that's what you don't want to have happen. So you don't want to go through the surgery and still have a positive margin. Now, everybody who gets a positive margin doesn't have a recurrence. And we're not sure which ones are which, but the higher grade ones tend to have a higher recurrence. If you have a positive margin, the treatment is to go to radiation therapy immediately. But unfortunately, it's a lower dose. And dose is related to cure when we get into radiation. I'll talk about that in just a second. But that's a good question, because to determine your surgical margin, there's a really good table made by urologists from Johns Hopkins, and it's called the Parton table. You can look this online, and all you have to do is put in your stage. It asks you for that, your grade, and your PSA. And you can put in let's take a T1C found only by PSA alone, Gleason 6, with a PSA of perhaps 4, and he has maybe a 15% chance of having a positive margin. But if we went to a Gleason 8 with a Gleason grade 8, and his stage was a nodule, a T2, and he had perhaps a PSA of 8, his chance of having a positive margin might be as high as 60%. Well, now you might want to think twice about surgery, because if we go to radiation, that would cure that tumor better, because a higher dose could be used when the prostate's intact. When the prostate's been removed, the only radiation they can give you is a field radiation, so it has to be reduced dramatically. And that'll become clear as we go into radiation. In radiation, there's two things you have to remember. The cure is related to the dose, and the side effects are related to the dose of the adjacent structures. What are we talking about? We're talking about the surrounding bladder and rectum. The higher dose they get, the more side effects you have. But you have to get to a critical dose, and the higher the Gleason score, the more refractory that tumor will be, the higher the dose you need. After surgery, the highest dose they can give you is, I'm going to give you a number, you don't have to remember it, but it's just a reference. It's 64 gray. 64 gray is like miles per hour, like 60 miles per hour. But in this case, 64 gray is about all they can give you, because then you'll start getting into toxicities to your colon, to the adjacent structures, the bladder. In Jacksonville, we have the Novalis, we have the CyberKnife. The CyberKnife and the Novalis are radiation machines that use photons like IMRT, and I'll explain this in just a second. And they're on robot manipulators. So they can take a course of radiation and reduce it from 42 treatments to perhaps 4 treatments. It has a lot of advantage, and you're there a prolonged period of time as the robot moves around with the head of the radiation machine shooting the beam through you. We have the proton beam in Jacksonville, and then we have the seed implant program. And Jacksonville has the 3rd busiest seed implant program in the United States. From here, you've got to almost go to New York City to find seed implants. Seed implants aren't done in every city. You can't get it in Daytona. Very few people do it in Orlando. There's, I think, a couple guys in Miami that might do it. You can get it on the West Coast, but it's not done as often. It's harder to find a seed implanter than it is to find a surgeon. A good one, that is. The most common type of radiation that's given is what's called conformal radiation. And in, for example, Daytona, I'm using that because they're our neighbor. That's all they have there. And it's, we use that a lot. It's called IMRT is another name for that. It's image-guided radiation therapy. And we have a machine that's called IMRT, IGRT. What this means is the machine can actually vary the type of radiation within the prostate itself. It can conform the beam to the size of the prostate. and it uses CAT scan or ultrasound or surgical markers that are placed in the prostate to help conform that beam just to the prostate. So you don't get scatter to the adjacent bladder and rectum, and you can raise the dose to the prostate. The proton beam, we've got one of 8 proton beams in the United States here in Jacksonville, and this is a very busy proton beam machine. It, instead of being able to actually conform the beam and alter it, what they do is the proton beam comes in and it only delivers its energy at the depth of the prostate. So they're relying on the beam coming in and dropping its energy just in the prostate. Brachytherapy is what we do. That's a seed implant. We do a lot of that at Baptist Hospital. We think it has a better cure, and we've published data. The largest series was published last year in the United States showing a very high cure rate. I can go over those with you. There's no hospital stay. It's done as an outpatient. And we find that there are less side effects because there's a lower dose to the bladder and rectum, and it gives a higher dose to the prostate. We most commonly use a palladium seed, which is a very short-acting seed. Across the United States, the most common seed is an iodine seed, which lasts 300 days. You never combine that seed with other radiation. But palladium is what we use. It only lasts about 90 days. It's dead after that period of time. The seeds stay in. They're coated with titanium. They're just like any kind of surgical staple that you would have if you had your gallbladder out or any type of surgery. So they're inert. And inside of those seeds, if I've cut one apart and there's a little grain, it sits inside that seed. It looks like it's sitting on a little throne. And that grain is the palladium. And these are not really radioactive until we put them through a cyclotron. And companies put them through the cyclotron, then we get them, we measure their activity, we plug it into a computer that tells us, we tell it what dose we want, it tells us where to put the seeds. It's all done in surgery under anesthesia. It takes about 30 minutes. And this is where seeds come out over the other forms of radiation. Remember I told you that after surgery and you had just a field, you could only give about 64 gray of radiation. Well, the IMRT, the proton beam, the CyberKnife, the Novalis, they're limited to about 80 centigrade, 80 to 83. That's about all they can give you. Unfortunately, the tissue around it, the bladder and rectum, all get a very similar dose because they can't cut the dose down. It's like a beam. With the seeds, our palladium seeds only radiate a little fraction. That's as far as they go. So what we can do is we can get the prescription line, the prostate up, to double that, 160 gray. Remember, the proton beam can only go up to 80 at the max, and they generally keep it under that. And if we look at a line inside the prostate, we can get up to 240 gray. That's 3 times higher. That is an enormous dose. That's what kills the cancer. And there's very little cancer that can live through that dose. Yet at the bladder and rectum, the doses are cold. They're down around 65, 64 gray, with really low doses. Dr. Turk is one of the main guys in town that does this. I do this with him, and we published our data last year. We began our program in '97. At this point, we have over 4,500 patients, but at the time we surveyed it, we had 4,000 patients that had gone through seed implants. All the patients were tracked, and we do approximately 500 seed implants a year. Again, just to summarize what our program does, we use palladium on day 1, and then we wait till day 60, at which point there's only 25% of the activity of those seeds still remaining, and we give a boost. And it's called low-dose delivery because you're giving a little bit every day over a long period of time. But the cumulative dose, with all radiation, it's a cumulative dose, is quite high. A CyberKnife and Novalis, again, they're robotic machines that take a generator that gives the IMRT, and instead of you laying there and the machine is fixed and you come in every day, it rotates around so it can fractionate it. It cuts the treatments down to 3 or 4 as opposed to 42 treatments, or in our case, we only use 25. All right, here's some of the differences. Which radiation therapy is best? Again, you got to remember the cure is related to the dose that you give, and side effects are related to the dose that you're going to give the surrounding bladder and rectum. If you look at the IMRT by itself, and that's what they have in Daytona, that's the only treatment, it's about 83 centigrade. Proton beam, 78 to 80. CyberKnife, up to 82. Seeds alone, about 170. And seeds plus IGRT, which is a seeds plus a boost, that's what we do, is about 170 to 180. But inside the prostate, we'll get up to 240. That's the advantage, especially in the high Gleason scores. That's the advantage of if you knew it ahead of time, you could look at the Parton table and say, geez, my chances are better off with the seeds since I have a higher Gleason score than with surgery because I might have a positive margin. And if you look at the bladder and rectum, our doses to the bladder and rectum are actually quite low compared to the others. This is a typical dose of proton beams versus seeds. And again, I might have some bias here because I don't own the proton machine. They're a competitor. But our dose to the anterior rectal wall is quite low. But because they're putting a beam in, they're going to have to get more bladder, rectum involved. They're going to have higher side effects than we are. Plus, they have to lower the dose. Cryosurgery is only for local disease. Cryosurgery is probably used by less than 2% of urologists. There are 3 in Jacksonville that use it. It's useful for local disease, and what these urologists generally try to tell the patient is that they're going to do focal cryo and just cryo in the area where the tumor is. If you freeze the whole prostate, as it was originally intended when they invented it about 20 years ago, the man has horrible incontinence, 100% impotence, they might as well have the surgery. So what they do is most of the time do focal cryo and monitor the patient. And it almost goes into an active surveillance mode. And this is where it's useful because you can use it as focal therapy for areas and continue to monitor that patient as he would in active surveillance. And I've already mentioned that that one study showed that active surveillance had the same mortality rate as surgery did. So this would fall into it. Just by watching the patient alone, whether it cured him or not, a lot of these patients are going to do fine. HIFU is high-frequency ultrasound. It's not approved in the United States, so you can't go down and get it. You actually have to fly off to Aruba or Jamaica to get it right now, and you have to pay cash for it. The papers that have come out have not been that encouraging. It's for local disease, it's for low-grade disease, but they're showing a pretty high failure rate and a very high scar rate. There's a lot of papers coming out in our literature talking about how hard it is to rescue these patients, to do surgery on them after they've had this high-frequency ultrasound. What it amounts to is a probe that's put in the rectum that generates an ultrasound beam, and the beam delivers its heat by dispersing its ultrasound inside the prostate itself. Again, there is no standard. If you look at the results of these things, 10-year PSA cure rates with low-stage and low-grade disease, the surgery and our IMRT are about the same. You can see the 97% rate that we have on cure. If I can get this to work. I guess, yes, 97% on surgery. And the only thing that'll match it is the palladium plus IMRT, IGRT. Now, when we go into high-risk disease, we're talking about the higher Gleason scores. That's where the radiation has an advantage over the surgery, because then your 10-year PSA cure rate drops dramatically. Cryosurgery is abysmal when it comes to high-risk disease, at 25%. And then, again, this is the regular traditional radiation. It has about a 90 and 80% cure rate. Proton beam, they have never published the data on proton beam, but we suspect that because it's a good therapy, we think it'll be somewhere around those if we think it's about the same as IMRT, because they give the same dose. And then iodine seed we've published a 95% cure rate, and high-risk disease, 85%. You got to consider the side effects. Incontinence. With surgery, it's a standard 10%. Some surgeons will say they're better than that. We always say that's what the nation's average is. We're not any better. We'll just say it's 10%. Erectile dysfunction, most people quote 50%. We think with surgery it's a bit higher than that. It's much lower with the radiation. You might think of it in terms of erectile dysfunction as one more straw on the camel's back, because most of these men are older. They have comorbidities like diabetes, hypertension, already having some problems to begin with. then you add one more thing, and it kind of pushes them over the edge. And that's true with surgery, too. With iodine seeds, it's not very high. Proton beam, a little bit higher on the erectile dysfunction. They have a little bit more incontinence, and that's because of the side effects of the external radiation getting to the bladder. Then just a note on metastatic cancer, what's new. The mainstay of treatment, and the first thing we always do for men who have metastatic disease, is hormonal therapy. Hormonal therapy is the mainstay. That's been known since 1954. In 1954, they found out that if you castrated men surgically, that cured the prostate cancer in a number of them. And it gave them a remission, and that average remission was at least 2 years. Well, now we have injections. In fact, I haven't done that procedure. At MD Anderson, we used to do probably 6 a day. When the new medicines came out, we don't ever do that procedure. There's actually a quotation in the Bible that says you're not supposed to have that done. I can't quote it, but I know it's in there. And we have anti-androgen pills, just like for tamoxifen for breast cancer. We have Casodex for men for anti-androgen. We've got a new injection called Zytiga, which works on the adrenal glands to further drop the testosterone. We've got some new chemotherapies that were approved this year. Provenge, which is the new vaccine we're administering. Right now, they are limiting it to people who have non-painful metastases and have failed hormonal therapy. We would like to give it to men immediately, as soon as they're diagnosed, so they can have their immune system working against it. Right now, the government's limiting payment to only guys that have failed hormonal therapy. So they're fairly advanced when they get the vaccine. And it may be that in the future they'll let us give it to patients who are sooner in their disease. And then we also use a lot of focal radiation therapy. Yeah, that 4 months is a misnomer in a way, because if you go back 20 years, there was a new drug that came out then, which is it's generic now, called Casodex. And it gave a 3-month extension over Lupron or castration alone. And that was, all the urologists sitting in a meeting would say, 3 months, why are we bothering with this drug? It turned out that 3 months was enormous. That was an average, and the individual patient, when that drug was used right, that was an enormous difference. So that 4 months was a huge, huge change. And no, it doesn't cut off any of your options. Chemo can limit your options for Provenge. That's one of the downsides of chemo, because it can affect your immune system, cutting down your white cells, so the Provenge won't work as well. We've had patients, we've sent off the Provenge to be treated. Provenge, for those who don't know, is you draw off the blood out of one arm, give it back through the other arm, and they take it and process it and take your plasma off, just like you'd have a plasma donor. They take quite a bit of blood. It takes a couple hours to do that. They get that. They send it to a factory now in Atlanta. They process it, and exactly 4 days later, we administer that activated Provenge back into the patient, and it's activated to go after cancer cells that have PSA, because it's activated against PSA. Very novel approach. But it's hard to assess its progress, because although PSAs go down, they don't always go down. How do you assess the progress? And the way they got it approved was looking at the time of survival. Well, that's kind of a hard way to assess. I wait till I die. So it's hard to assess the success of that drug. You can do bone scans and the CTs, whatever initially got that patient determined to be hormone refractory in this case. Then the last thing we're going to mention about is just cancer prevention. We know that a high-fat diet, especially meats, red meats, has been proven to increase. We think that there's probably, when they look at it, there was a much lower incidence of prostate cancer in certain countries, like Japan. We thought it was because of their soy, their fish. And I think in autopsy studies, they're actually finding out their cancer incidence is probably the same as ours. But we do know that the higher fat diet does make a difference. We know that countries that have low sunlight, they don't have vitamin D. That increases their incidence of prostate cancer. Lycopene has been shown to in some studies, to help prevent prostate cancer, although a recent study said that didn't work. Two medications, Proscar and Avodart, do reduce the incidence of Gleason 6 adenocarcinoma quite a bit. And actually, we ran that study as part of one of the extensions here at Baptist as other places 15 years ago. And they did show there was a marked reduction in the incidence of prostate cancer, but there was a slight increase in Gleason 7s. And so the people who made Avodart went to the FDA and said, we want an indication. We want everybody, all the men on Avodart to prevent prostate cancer. They said, well, wait a minute. Let's look at this. And they did, and they said, well, yeah, you did decrease the risk of prostate cancer, but those are the ones we can watch anyway, so who cares? You actually increased the risk of the high-grade cancers. So they said, no, you can't do that. In fact, now, if you prescribe that drug, you better tell them that you can increase that risk of the high-grade cancer. So now we have to tell everybody. We have to disclose that. And so they went and came back with egg on their face. Vitamins D and E, we ran a study where we gave vitamin E and selenium. Actually, it was called the SELECT study. That went on for 10 years. They actually found that the men who got the vitamins and the selenium had a higher incidence of prostate cancer. So they said, stop that right now. So that's all been taken out. And I think that most of it is just diet at this point. I think what you can do mainly is just maintain a healthy lifestyle. You know, your sleep's important. Look out for those people who are snorers, sleep apnea. Those are the main things. Anytime you have a chronic disease, whether it's blood pressure, diabetes, those things all add in and give you a higher risk of prostate cancer. Anytime they look at studies, they find that men that have comorbidities like diabetics, hypertension, cardiac disease, they have a higher incidence of prostate cancer. It just lowers your immune system. So just basically being healthy, you know, watching your glucose, not too much alcohol, a lot of sleep, exercise. And we're ready for questions.
First, thanks for coming.
Well, thank you.
I found out last Friday that I have prostate cancer. So I've been reading a lot over the weekend and up through today. One question is, it's a different side effect that I have an interest in learning about more, only because I babysit my grandchildren every day. One was born a week ago Saturday. Okay. My question is really around this whole idea of the palladium, because whatever I read or talked to people, the seed implant sounds of interest to my mind at least. Palladium, you said, goes on in day 1. And then in day 60, you have the IGRT. The basic question, how long do I have to be away from the baby?
That's a good question. In fact, we had a guy there was a mayor in Fernandina, he was visiting Fernandina, and he was going to see Bill Clinton. And we got a call from the FBI. They said, this guy is radioactive. And he had just had his seeds. And he said, he's saying he has seeds in his prostate. This guy's crazy. We're going to throw him in jail. And we had to say, no. Dr. Turk actually got the call. And he said, no, this is true. We've had people, there was a guy in Moscow who was pulled over by the KGB because he set off a detector. And we give letters to guys because you will set off a detector. Guys are walking around with these things that look like beepers in the airports, and they'll pick up radiation. But to the person next to it, like to the person sitting next to you, there's no risk to an adult. All the risks to children are all theoretic. No one's ever been hurt by the radiation, but it's just kind of common sense. And we tell people, think of a barrel around you. You could sit next to somebody if you had about this much distance for about a 2-month period would be safe. But you wouldn't want them on your lap. And again, no one's ever been hurt. It's all theory. It's just common sense stuff. But it's really not that much radiation. If we see all these patients, you know, if we'll treat 6 patients a day and see them coming back to the office, we take no radiation precautions to shield ourselves because it's just such a low level of radiation. It's far more being in the airplane at high levels. You get far more radiation than you'd be exposed to sleeping next to a person who had seeds. It only lasts, he asked how long it lasts. It really only lasts for that 2 months because after 60 days, there's so little activity in those seeds that it's negligible and it's not a worry. In fact, the machines can't even pick it up at that point.
What role does heredity play in prostate cancer?
What was the question?
What role does heredity play in prostate cancer?
Oh, that was a great question. I should have asked that question myself. And for every blood relative, it's 1.5 times increase. So if you have 2 blood relatives, it's a 3 times increase. So if your uncle and father had it, that's 3 times increase. If you have a brother that had it, that's 4.5 times the increase. We have biopsied men who had a lot of family history. I had a 35-year-old with a 0 PSA. You couldn't even find his prostate on an exam, who had adenocarcinoma because his father had it, his brothers had it, and so he wanted to know if he had it. I said, the only way we can find out is put you to sleep and biopsy you. A 35-year-old, he was getting married in 6 months, and he had it. So, I mean, it's very hereditary.
For healthy males over 65, how often do you recommend a PSA and a digital exam?
AUA still says once a year. Now, the family practice guys have suggested perhaps once every other year. We can see significant changes if someone's diagnosed with prostate cancer. There was a lawsuit in Jacksonville about 15 years ago where he had a normal exam, and then 1 year later he had metastatic disease. So things can change in that 1 year. That's why we use 1 year. And yeah, it can happen in 1 year. And aggressive tumors will do that.
Doctor, what is your opinion of green light surgery for BPH?
Green light surgery works real good for BPH. It's what he's talking about is this laser that we go in through the urethra, and it's not for cancer, and it's just for an enlarged prostate. And the nice thing about it is it seals the tissue as you go, and so you don't have blood loss. And that's especially useful for big prostates, because very big prostates a patient can lose a lot of blood if you're trying to trim it the traditional way. Well, with the laser, you don't have that problem. And the nice thing about that is you don't have to get all the tissue out. You just make a big enough channel, and that patient will do fine. So we like the green light a lot.
I have a follow-up question to that. If you've had green light surgery, can you get off Avodart?
Can you get what?
Can you get off Avodart?
Oh, yeah, yeah. Although there are some guys that have such huge prostates, you do a little green light and you still keep them on Avodart because their glands are so, that's very unusual. It's very, very unusual to have a patient that still needs to have Avodart on top of the surgery.
I noticed under diet you had fat.
Yeah.
I was trying to figure out, did you mean increase your fat or decrease your fat?
You want to decrease your saturated fats. So it's saturated fats that are like butter, and red meat has more saturated fats. And of course, there are carcinogens that when you barbecue, they think some of that does it. Smoking actually increases the risk of prostate cancer a little bit.
Doctor, if your primary doctor told you, not me, my husband, he has a hard prostate and quite enlarged, will it lead to something bad?
Not necessarily. Again, PSA is not cancer specific, but if his prostate's big, let's say a man has a very large prostate, he could have an abnormal PSA and still be normal. And we don't necessarily biopsy all those. We follow them. If their PSA is stable, we don't necessarily biopsy those. We have a lot of those men that we follow that have abnormal high PSAs, but because their prostate is so big, we consider it benign.
No, his PSA is normal,
0.4, wow. That's real low. Yeah, he's probably okay. Yes?
If a male never had a PSA test, is there any pain or indication that they are having problems with their prostate?
No, see, that's the thing. The symptoms of prostate cancer, if there are any, are the same as the benign enlargement. And it's usually after the cancer's gotten quite far that would occur. So if anything, we like to say there are no symptoms for prostate cancer.
Thank you for a very informative presentation.
Thanks.
My question is that I was told that active surveillance was appropriate for somebody in their mid-60s, but somebody in their late 50s, it was not recommended. What are your views on that?
Well, that's where this new NIH consensus came out, because now they're questioning that. The old paradigm was that if the man had less than 10 years of life expectancy, that man was definitely an appropriate patient for active surveillance. Then they opened it up to, well, maybe the life expectancy is not so critical. And now they're opening it up to 45-year-olds, and now they're rethinking the whole thing. And active surveillance can be used for a lot more men. They're questioning it. That's right now we're on the cusp of that. I mean, we're talking, this stuff has just come out in the last 3 weeks. And you go to NIH consensus and you'll look up NIH, look at their consensus report. It'll just be amazing to you what you'll find. I was amazed. Yes, sir. Yes, ma'am.
My question is, you mentioned that after the seed implant that a patient will come back for a boost. How is that boost administered?
That is with the traditional radiation. It's only a 5-week period. It's much less. And I've had some men who actually wouldn't come back. They lived out of town and they just said, I'm not coming back. I've had enough radiation. Actually, they did. We looked back at their doses, and their doses were 110 centigrade, which again was 30% higher than a regular proton beam would give you. So, and they did fine. But our data that we've looked at, we had a 97% cure rate on Gleason 6s and 7s with the combination therapy. And that's about as high as you can get. And we're not the only ones who have that data. I mean, Mount Sinai, New York had that data. We matched their data, but it's valid.
So is this boost external? I mean, when you
it is an
boost,
external
it's
boost.
external
Yeah.
procedure?
Yeah, they come in from the sides.
Oh, okay.
But it's not a cyber knife or anything like that. It's
Oh.
just a regular conformal radiation. And what the machine does is it uses a CAT scan to see the seeds, and it only radiates what it knows is prostate.
Oh, okay.
So it doesn't hit the bladder, doesn't hit the rectum.
Okay,
That's
thank
how
you.
we can get our doses so low.
Yes, hello, doctor. A question about if there's any type of link between chronic prostate infections and eventually developing prostate cancer.
Yeah, they've looked at that a lot, and the answer is no. But there is a link between an enlarged prostate and a higher incidence of prostate cancer, and they're not sure why. But the infection is actually no.
Hi, you mentioned that you didn't often see patients with a Gleason score between 8 and 10. I was wondering, is it because those particular patients waited to be observed or diagnosed with the cancer, or is it the tumors were aggressive?
Yeah, it's because of the second one thing, which you said, is the tumor's more aggressive, so it appeared quicker. Most of the time, when you have somebody that had a normal exam a year ago, and now the exam's abnormal, and it's a high Gleason score, those tumors grow rapidly. Whereas a Gleason 6 might double every, talk about tumor doubling times. It might double every 4 years, 2 years. A Gleason 8 to 10 could double in 30 days. They're that much different. It's almost like a different kind of cancer. Yes?
Doctor, prostate cancer been around forever. Is it more or less, or more people dying or less?
More or less.
Prostate cancer and death.
Then what?
And death.
Death, dying.
Oh, the deaths are actually going down a little bit, but they've stayed stable at about 34,000 per year. That number's stayed pretty stable for a long, long time, but it has gone down. The diagnosis, actually, when they found PSA, went way up. Now the diagnosis is coming down because we've actually diagnosed all these people who were out there that were just hanging around and no one knew about. So, but the death rates come down because, again, we're catching this so much earlier. I used to have, let's say 15 years ago, 20 years ago, I would have probably on average of maybe 20 patients a year that would die. I'm going to have 1 this year. This is a big difference.
Yes.
Right over here.
Over here.
Yes, sir.
I heard on the news recently that charred meat and well-done meat contributes to prostate cancer.
Yeah, that's what they were. Some of this stuff on the barbecue was.
Yeah.
But they haven't really done a good study on that. I wish they would. I'd be in the barbecue arm. But they think that is, because there's carcinogens that are developed, and then what they're seeing more of is colon cancer as opposed to prostate.
Okay. Thank you.
Yeah.
Thank you, doctor, for coming out today. I've been on Lupron and Casedex for 5.5 years, and they took me off of Casedex about 90 days ago. Prostate has gone from, about 10 to about 15.9. They're trying to decide is Provage the next thing, or is it something in between it's better or is good or whatever it is. That's $100,000 for 4 months of treatment, and so I don't know if my insurance is going to cover that or not. But so my question is it something as good as Provage?
Yeah, that's the standard thing, is to go on, and this has changed in the last 9 months. And the next thing, when tumors become hormone refractory, before they get chemotherapy started, they can alter the immune system. We like to get them in, get the Provenge started. It's working in the background. Spot radiate things as they come up, try to control any disease that's popping up locally. And then if the disease still progresses, then you can go on to the chemotherapies, because the Provenge will still be working all that time. And then they have the Zytiga as a backup. And that's the cascade we're doing now.
So you would go from the Provenge to the Zytiga?
Well, right now the government makes us do chemo before Zytiga. They won't allow us to get Zytiga yet.
Thank you so much.
Yep. Well, thank you.
One more, and this will be the last question.
Yes, are there any studies that on a small indolent tumor that diet could possibly either stop the growth or even reverse it?
No, they don't have anything like that, because it would require sequential biopsies, and they don't have anything like that. All they have is the prevention studies like the SELECT, where they used the diet and they looked at vitamin E and selenium, which actually found in those vitamin arms were higher incidence than, than the placebo arm.
I also read that there's some indication that high doses of vitamin C might actually aid tumor growth.
Again, I can't find anything on that. You have to watch your vitamin C. You eat a lot of it, you'll get a kidney stone. So it's. Well, you guys have been a great audience. Thank you very much for attending.
Thank you for coming out today.
Thank you.
Just a reminder, please, to fill out your surveys and hand them to Marion in the back of the room. And thank you all for coming out. Have a Merry Christmas.